Hello everyone, my name is Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel, click our notification bell.
Good evening, everyone. Welcome to another edition of Cornwall Cancer Foundation, focusing today on prostate cancer, the treatment options. My name is Denise Ejo. I am the CEO, whatever, of Cornwall Cancer Foundations. I live with cancer, and our awareness program will be speaking today. Will be spoken to today by Femi Esson. You can welcome him into the house. He's the one that is going to be telling us how and what men need to know and do to prevent or at least support themselves in the midst of or in the challenges to do with prostate cancer. So Femi, we welcome you tonight. Thank you for coming. Thank you for agreeing to be part of this program. Thank you for your willingness to engage and to share your experiences in a very public space. I know that this is always a very difficult conversation for people who have gone through cancer. So I want to say thank you and welcome tonight. The floor is yours. Have a nice time.
Thank you, Dennis. Yeah, the topic, the treatment option that our last session we talked about the prostate itself, how to take proactive action, the disease itself. Now we are on the treatment option. Yeah. Now, one thing I want to let you know, I'm not a doctor, I'm not an oncologist, I'm not a urologist, I'm not but the thing is just from a layman perspective, which will also be beneficial to everybody. I will not be able to do so much justice to it, but if you have some doctors in the background who can do it, you can help, well, you'll be very, very, very welcome. Yeah, the first thing that is very, very important is that depending on the case, because every case is different. Every cancer issue, especially for the prostate, they have it. The doctor will have to evaluate the patient and be able to recommend something. And depending on the case and the evaluation by the doctor, he will be able to recommend the best treatment option for the patient. Well, before I go ahead, I would like to talk about the various types of doctors that handles issues of prostate. We have the urologist. The urologist is a surgeon who treats the disease pertaining to urinary tract system and also that handles the issue of prostate for men. You have the radiation oncologist, and that's a doctor who treats with radiation. And also we have the medical oncologist, a doctor who treats cancer with medicine such as chemotherapy, the mammotherapy, or the hormone therapy. So you'll be meeting a lot of big names along the line. So, like I've said, the real issue is that depending on the case, the doctor may say, let us just observe. That will depend. That's what we call the observation and active surveillance. They may say, okay, you're going to go for surgery. There are different types of surgeries. When it comes to this issue of prostate, we have what you call the radical retropubic prostatectomy. You have the perennial approach. I don't know if I'm communicating now. Then you also have the laparoscopic radical prostatectomy. Then that is when you're talking about the surgery. I look at it from doing surgery or something like that. Then you also have the radiation aspects. When you're talking about radiation, you have the open radiation. You also have the one that you use is actually directly focused on the prostate itself through what you call the linear accelerator. Then you also have the seed radiation, where you just insert a seed into the prostate itself, and then you start monitoring the doctor will now take you through some monitoring phase. Then you also have what you call the cryotherapy. Then the hormone therapy too, because it is believed that okay, prostate is also more or less linked to your hormone. If your hormonal level is high or something like that, some doctors want to treat you with hormone. I mean, there are some drugs that will be given to actually reduce the rate at which the hormone affects the prostate. Then, well, everybody knows about chemotherapy. Well, that is the advanced stage. Then you also have what's called the immunotherapy for prostate cancer. Well, with all this, it will depend on your doctor. It is the doctor that we recommend. Because before you can go for all this one, there are a lot of things they have to consider. You have to consider the stage of the cancer, the Gleason score, which is they call the grade, the age of the patient, if you have some underlying illness, something like the patient is diabetic, hypertensive, the doctor will have to advise you on how to go about it. And also, most importantly, your feelings about the approach that the doctor wants to use. Because if you are not okay with his approach, because each of these treatment, they all have their downside and their upside, and that's why they always say, if you are of a certain age, don't do this. If you are certain age, don't do this. Don't do this. And if the Gleason score, you see, because there are some cancer that they multiply so rapidly. There are some that they are slow in their growth. So the ones that are slow in the growth, the doctor may say, okay, let's just observe. And some of and they also depending on the PSA level of the patient. Whether the PSA level of the patient, if it's a very less than 10, it's okay, let's still observe. It may be what they call the benign prostate hypertrophy or something like that. And then you now say, okay, let's observe, let's take your PSA, let's be observing how the PSA be, if it's growing fast or growing. Then also, we also want to check, okay, let's go and check, do some other tests. Let's do what to call the MRI. Let's check all, and then at times you maybe want to check if you have they want to do the bone scanning. The thing has gone to the bone, and because the doctor wants to have a very good picture of how he's going to approach the case that is treating. Then another thing that is common these days is that some school of thought are talking about diet, they're talking about vitamins, they're talking about herbs, they're talking about acupuncture, and all. Those are the non-conventional approach that people are using these days. But the thing is that I don't have any scientific data to back all those approaches. Some guys they said that it works for them. Some guys say it doesn't work for them. But the thing is that my own advice is that when it comes to the issue of cancer, you see, if it is not treated early, it may be fatal. I don't know if I can just pause a little while I take some comments and observation before going ahead. Hello? Somebody is raising.
Hi, Femi. You talked about the PSA, about something if it's 10 or under. What is PSA?
That is prostate specific antigen, and maybe a doctor should help me there. Prostatic specific antigen. Am I right? Yeah, okay. I think I'm right. I think I'm right. Somebody said okay.
Everyone has answered.
Yes.
So under 10, the cancer hasn't spread, or if it's above 10, then it's really
not necessarily, because
right.
what the doctor, the oncologist, or the urologist is trying to check is that he will look at it vis-a-vis your age. Because one thing is that if they is still less than 10, they may want to check. We want to look at some other things. We want to check if they can manage it better. Maybe maybe it's still within the confines of the prostate itself. Maybe.
Okay, just to add, because of the question, I thought I would catch up with Juliet, but somebody else might be asking the same question. You see, for a number of cancers, you have what we call tumor markers.
Okay.
Yes, and the values. What happens is that the values are, a general guide for what is going on in that organ. Like you have tumor markers for ovarian cancer, for uterine cancer, and things like that. But specifically, this PSA, the prostate specific antigen, is a marker for the prostate cancer. But the thing is, just like Femi is trying to explain, is that it's subject to it has to be. It's not always. You can't always analyze just the numbers. You have to look at the numbers as a complete, and the patient as well. You have to consider other things that are going on in the patient's life, especially if the numbers are not very raised.
Correct.
Like what he's talked about, that 10, it could be that, there are times when a patient is somewhere borderline, and what is happening is that clinically, he shows all the signs of actually having prostate cancer, all the signs of prostatism, and, and then his age also, because the age is also an indicator, also falls within the age, because the elderly are more susceptible to it. Yeah. But if you just have, randomly a very young person is very high, then somebody wants to take a look. Again, in this day and age, you don't want to say, no, it's not possible. But at the same time, you're saying it's not really likely. Maybe there's something else that is explaining it. That's just what I wanted to add. Mr. So go on.
Yeah, that is for the that's for the observation and active surveillance. Now, when you talk, the surgery is another aspect that's the doctor will have to evaluate properly before actually not wanting to just put a patient on the table, on the surgical table, knife up the day, and then find out that, oh, I could have done something else. So they're always very, very careful before they go into that. You see, we have about 3 types of surgery. You have what they call the open surgery. That open surgery, okay, the doctor, they will open up the patient and then try and remove the prostate itself. Then you also have what's it called, the radical prostatectomy. That one, they will remove the entire prostate and also the entire tissue around the prostate. Now, then you also have the one they call the laparoscopic radical prostatectomy, which is the latest one that they are trying to offer people these days. But one thing is that, you see, when you say laparoscopy, it's like they're exploring, trying to make sure that you don't. They always use they engage the use of the robots with it, and then all this one also they want to know. It depends. It also depends on the evaluation of the posture of the tumor marker itself, because if the PSA is high, and the patient has started having some issues like swollen legs or something like that, somebody start having some inhibitions or start having some bleeding through the urethra. Then you want to know whether the thing has actually spread beyond the prostate cup itself, because the prostate cup has a limited space, and when it has spread beyond the prostate cup, it goes straight into the lymph nodes before being transferred to other parts of the body. You want to be sure that, okay, and if you know, some people are still asymptomatic, it's concerning, they may not have some symptoms. So, but if the patient is young and you are now saying that, oh, you removing the prostate may not be too okay. You want to make sure that the patient still have some active life. So you may want to recommend some form of therapy. But before going to that aspect of therapy, let me go ahead with the surgery. That radical prostatectomy too is also divided into two aspects. You have the type when you approach the patient through the perineal. They call it perineal, through the anus, and then we also have the one that they call it retropubic. The retropubic is like they want to know if actually the cancer has spread beyond the prostate, and then during the surgery they may want to quickly do a quick test, taking a sample of the lymph nodes, and if they find out that you have the cancer cell inside the lymph nodes, they will say, oh, this is risky. It may not even be nice for you to even remove the prostate itself. So you probably close up the patient and then use another approach for it. Because if you remove the prostate and you also remove the lymph nodes, there are also some downside to it, because you start having some swollen leg, you start having a situation where the patient will be having to be draining fluid and all sort of things like that. Then also you have the retropubic, the laparoscopic one. That one also has its own downside. That is the one that you have although the three types of surgery, they all have their risk, but the laparoscopy is one that has the biggest risk in reality, because especially men that has issues with not wanting to lose their erection, we have the erection and all sorts of things like the erection problem. Although all of them, they all have a high degree of retention of the erection, because the thing is that you don't want to see where you cut the nerves out, the nerves that actually supply the blood to the penis. But you see, if you now go through, if they are trying to use another type of surgery, where your doctor is a little bit more careful, even though if the doctor cut off some nerve and be able to preserve some, of course, by the use of because I was just reading that one yesterday, the use of some what they call the drugs. I forgot what they call this type of drugs, the Viagra, the Cialis group of drugs. They call them inhibitors. Yes, that's what they call them. Inhibitors that after some time you may even be able to help them with their erections. Then that being said about surgery, because I may have to refer you to a lot of literature on that surgery if you want, if you're on this program, and if you want, so that you'll be able to read more about it. Then another aspect is the hormone therapy. The hormone therapy, a lot of people, they want to a situation where, okay, they will say that it has not gone far. They want to start taking some drugs. I don't want surgery. I don't want all these things. And then find out that, okay, they do an hormonal assay and to realize that, okay, some form of antigen that also helps in the production of the semen is very, very, very high. So they start giving them some drugs. But the hormone therapy is not always recommended for younger people. It's more or less for people that are where maybe in their 60s, and okay, just so that at least they can reduce the rate of spread concerning the cancer. That's for the hormone therapy. Then you now have the radiation therapy. The radiation therapy. There's this one that I really don't understand that I saw when I was going through something. They call it cryotherapy. Cryotherapy, I don't know what it entails. Maybe the doctor in the house will be able to elucidate on it as we move on. But the other type of something they call the radiation therapy, that's the therapy that I was trying to explain in the first session the other time. You know, you have that radiation therapy where you have to beam the ray. You have the open body radiation. Of course, that's the commonest of them all now in Nigeria. So we go through radiation, and the whole body is radiated. And at the end of the day, even those cells that you don't need, the radiation kills them all, which is it could be dangerous. But with the linear accelerator, where it is targeted, you just take the patients through what is the machine is like an MRI machine. You take the patients through it and then focus it. Look at that area, design the amount of, because the radiation oncology will have designed the amount of radiation that is needed for that particular area that we are talking about. Then the brachytherapy. Of course, the brachytherapy is like it's an hormonal seed. I mean, I say hormonal seed. It's a radiation seed. I don't know the type of seed. It's a metal. It's a minor surgery. They just insert it inside the prostate and they allow it the seed to radiate over time and it melts over time. And that is the aspect that those are the areas where I have been able to. I can do some justice to now as we have been able to talk about. Any question and more contribution, please?
Hello, Fami. Thank you very, 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 very much for that. Any questions in the house? The one question I have, and if you have any questions, you can actually write them in the box and I will read them out. So let me start from this point now. I'm going to go with, first and foremost, based on your experience, based on your challenges,
Correct.
What would be a guide in helping an ordinary person make the right decisions? So what 2 or 3 things do they need to be asking a doctor? You see, I'm a woman, so prostate is not mine, but like you say, and we crack the joke, women will tend to go with their husbands on this kind of discussions. So men will be quite confused. So anything they're saying, all they're looking at is about their own needs at the time. But what would be give us 3 main questions that anybody will need to ask to be able to make the correct decision going forward.
Number one.
Experience. You're not a medical person. And let me not.
A man who is in his late 60s or maybe early 70s, who may not be too worried about his erection, because that is one thing I found out about men that I've discussed with concerning this issue of prostate. A lot of them are concerned about their erection, their emotional needs with their women. So if the man is in his late 60s or early 70s, and well, of course, I don't want to use the word useful life, because everybody, even a person of 100 can still have a lot of. I would say that, okay, just do radical prostatectomy straight away. Radical prostatectomy is fast, it cures, it takes away the entire cancer cells out of the body. And the healing is fast. Now, if you are young, like me, I was diagnosed of cancer in my 50s. I still want to have a lot of emotional connection with my woman or something like that. So that was why the issue of brachytherapy was recommended for me. And that was what I did. And then, because the thing is that of all of them, the rate of losing of having erectile dysfunction, that risk is there. But with brachytherapy, it is less, because the statistics have shown that 80% of men that did brachytherapy actually got back their erection. But with radical prostatectomy, most of the time, the result is very, it's not encouraging for men. Then you have to start using vacuum, you start using some other thing, and it will be frustrating for a lot of men. That is the second thing. Then the third thing is that you actually want to live. Do you still have responsibilities? Do you still actually want to live? Some people will say, "I rather die." Some men will say, "I rather die than for me not to be able to perform my role as a man or whatever." So if that is the choice of that man, well, what can we say? So it depends on how. It depends on what the person actually takes into. It depends on the value something of the man that is going to. That's why most doctors normally have a comprehensive discussion with the men with prostate issue. I hope I was able to do some good justice to the.
Any questions in the house? If you have a question, just put up your hand and let me ask, and we can just ask, or write it if you don't want to. Yes.
It's just to add some. Yeah. Thank you, Femi, for this explanation. I just want to put some things in context again. The size of the normal prostate is like the size of a walnut. That's what it is really said, or a small golf ball. Yeah. Now, and the reason why I've said that is to say that what happens in terms of the treatment is a function of what happens to the size. So you have a typical ways by which these walnuts can increase in size. It can go from the size of a walnut to the size of an orange or whatever, but the direction of the growth will usually predict the type of surgery, for instance, because people are going to, because like Femi, I think he already mentioned it last week, that the prostate surrounds the urethra, and that comes through is just under the bladder. So if it's easier to go from down below, if the decision was for surgery, then they'll go from down below. If it's easier to just do it from up, and if the decision is actually that the cancer has spread so much that they are not even going to do surgery, that they are just going to do something that is palliating. So sometimes there are other things that influence the choice. And sometimes the treatment will actually influence this issue of erection or no erection. So they're all very related. It's not just that one aspect stands alone. They are all related, but you have done excellently well. Now, I just want to ask, because I know that you have a wealth of knowledge of what happens in Nigeria. You had your treatment in South Africa. And thank God for that. But I'm just wondering, what do you know about treatment? Not the details, not the fine medical details, but just in terms of signposting people. If there's somebody, that is calling in from Nigeria and they're wondering, because in most countries abroad, you have structured according to age. You have screening plans. And your GP is sending you a letter, there is a reminder, so that even if people didn't have the symptoms or were not aware of the symptoms, then somehow they should be caught, just like you have with breast cancer as well. But I'm wondering, in Nigeria, are you aware of such a program, Femi?
No, you see, the thing is that, funny enough, I was more or less in the structured environments. You know what? Like I told you earlier on, I was working for a multinational company, and because we do this thing often, what we call the fitness to work exercise every year, that one really helped a lot. But for an ordinary person in Nigeria, the only thing we can say is that we need a program of awareness that we actually, I don't know if for the teaching hospital can handle it, or maybe through some NGOs like what we are doing now, to be able to take the information around. Because what I know is that most of the time, until the cancer actually hits people in Nigeria, most people don't really know what is going on. You want to say something? Okay, yeah. You see, most people really don't know what is going on, because and most of the time, you find out that it's even the doctors that are actually going to handle the patient, they are even confused, because they will not be able to tell the patient the truth about how far the cancer had gone. But you see, unlike maybe in England or in the US, where you do like some form of routine check that and everybody is a little bit aware. I don't think that is the only thing that I can say is that there should be some form of orientation program for everybody. Just like I said last week, once we are over 40, over 50, you should start taking some your tests. A lot of people just go through their life. They rush, wake up in the morning, bam, bam, bam. Then wake up in the morning, go to work, come back, go to money, eat, go to work, come back, and not necessarily taking care of their health. I've heard people saying that they've not seen a doctor. I've never been to the hospital for the past 10 years. I think that's dangerous. You don't need, when I hear that, I always tell people that is not good enough. But mere fact that you're not having any symptoms does not mean that something is not going on, because the body has a way of deteriorating with age. That's all what I can say to that.
Okay, Femi, can I ask you a very quick question now? If even to create an awareness program in Nigeria, and I'll give you an instance. This particular event, for instance, was shared across both countries predominantly. And we have quite a lot, actually. We have majority of the people that actually registered are from Nigeria, but majority of the people on the platform are not from Nigeria today. And that tells you something, which is the worry. Because no matter what you say, so based on that, the question I'm going to ask is how or what is I'm backing up from Ebun's question, that we can agree that there's a need for awareness, but entering into the system that allows the people that it matters to actually get in, and I'm going to call somebody else to come in on this one for me. And Nobe, please, you're going to also come in on this one for me, wherever you are. How are we going to go forward with it?
Sorry, thanks, Dennis. Like you said, on the matter of awareness, not too long ago, prostate became very common here, and then there were a lot of leaflets, a lot of things going around. Like my dad actually suffered it.
Yeah.
He was close to 80 then. But the first thing we did was to check if it was a cancerous prostate or not. But luckily, it was not. And it's about 7 years, going to 8 years now. He's been just taking drugs and it's been okay. But the awareness we try to create, even let people know, especially the young people, because it's very common. They said once you are above 40, But like you know, most of us down here very religious. The next thing you hear is not my portion. It's not my portion. So it becomes very difficult. You can't force anybody. It's very, very few people. Maybe because someone close to you has experienced it, you now say, okay, let's go. Even our own platform, we have some other platform, we talk, we discuss this thing and say, you guys, have you done your check? Have you registered? Listen to this. But everybody is just like a Jessica about it. So you can't force them in terms of the awareness. That's how I would say.
Fabi,
Can the church help?
Contribute to this now. Yes, it's a man.
Yeah.
You see, it's a man thing. If you're saying to me, and most of us here are women, if you're saying to us how to be aware of what's going on with the women, trust me, we don't have problem with that. But men, how do you do an awareness program that actually promotes this? Because for one of the things I do know is cost of doing the PSA is, depending on where you are even doing it, ranges between 3,000 and 10,000 naira.
Correct.
So what is the issue?
That's correct. That's correct.
So what is the issue? Why do men have to wait till it becomes the point where they are dying? Everywhere else in the world, most men don't die anymore of prostate.
You see, the thing is in Nigeria, I know Nigeria is a very, very religious country. We are very, 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 very religious. If you want to, sorry, I just have to violate it. If you want to win an election, if you don't carry the church or the mosque along with you, probably don't win that election. But I think the church can really help. You see, if there is a constant, because most people that goes to church, especially men, until a man is challenged, most of the time they don't go to church. That's the truth. Most men are in church because they are challenged one way or the other. Same thing with, so the thing is that you can easily make people to listen to what you're going to this kind of orientation through the church, through the mosque, or through whatever. Because we are all busy trying to provide for the family, trying to make ends meet, and all sort of things like that. So I think, and also that's the first thing. The second thing is that I don't know if the Ministry of Labor, government institutions can make it a point of policy that they should be doing the kind of thing that we were doing in our own company, like fitness to work. Every year, make sure that your staff are in a healthy condition, and then if they are challenged, they quickly take care of it. I don't know if that is a useful suggestion in this forum.
Thank you. I'm just thinking, I don't know what people have to say on this, because one of the things I've learned, maybe because I actually also do education, and that's my profession, one of the things I've found is that in Nigeria, it's every other person's illness. And then when you want to now say you want to do advocacy, you are bribing your way to advocacy again. It's quite frustrating. And honestly, it is easier to actually find funding to support cervical cancer, any women, you will find funding. But when it's a man's zone, you won't, because men themselves are not even engaging in it. So even if you go to a church, it's a woman that will run. I did a one for cervical cancer. I think cervical cancer. Might have to help me on this one. The one that the young children take, the young girls take. I think
that's Everett's.
Is that
it's cervical cancer?
Cervical cancer. Okay, cervical cancer. Now, one of the things I did find was I had a conference on that for parents in a school that I was at the time the chair of governors, and a woman parent, went straight back to where she was. She was in Port Harcourt, and our school was in Lagos. Said she wasn't feeling very well based on that discussion, and was able to nip in the bud the start of cervical cancer. But she took it seriously. Now, she sat there, she heard it, when I was doing it, there was a bit of resistance that why am I having to talk about cervical cancer to parents? And I'm sitting there saying, well, we're all parents and we have children to raise, so we need to know. But at the end of it, I felt very accomplished as a parent that at least one person heard it, and that one person, it made a difference, and she's still there, and her child has finished secondary school. So but men, it's so hard because getting men to get involved makes it serious. And they are the ones that, funnily enough, they are the ones that even make the decisions. You go and count how many people are in House of Rep. Majority are men. How many people are in Senate? Majority are men. Who are the ones going to vote on this thing? Men. But the men are not interested.
Well, I don't know, because you see, let me tell you this.
But that's the question I'm trying to rotate, because let's look at it carefully, because it's important for us to make an impact, one way or the other. But making an impact when you're throwing away money is not a viable impact.
No, I think also, because Femi has said something, I think also the corporate community is becoming more aware, because you find out that a lot of people that are, that belong to maybe 30 plus, doing quite well across the world, but particularly in Nigeria, because we're talking about the Nigerian story. You find out that they're now having seminars. They are taking the issue of making wills. They are taking these issues of planning for their end. They are taking it more seriously. Look, you only have to look at the obituaries, even across with this COVID issue. It's not limited to people that are over 90.
Correct.
So people are beginning to talk more about it, but I agree with you that it's still not, right there. But I think it's just, it's more about engaging like minds. So it might be a group of churches, like Femi has said. It might be, an organization. It might be Shell. It might be one of these. It might be a school. What you just described is actually brilliant, because that is actually good. Do you know the average age for cervical cancer has actually come down to the 20s? So even those children, the information is never too early to have some of this information. And that is what they are trying to do now abroad, because some of these cancers, especially with all of the research that is going in, they are finding out that some of them are almost becoming like chronic illnesses. That, if you nip them in the bud, or if you avoid certain things, the chances that one will have it, of course, we pray and God on your side, but the chances reduce. So I think we should just keep at what you're doing. Maybe if anybody on the forum has access to a men's show, to a television show, small things like that. I did a cancer talk once in one of the embassies. And during the talk, somebody came and met me and said, you know what, my community has to hear this. Took me into a Ghanaian, completely Ghanaian community. And I had spoken at the Nigerian embassy in the Netherlands at the time. So what I mean is that, as we're dropping the seeds, eventually the very right people will hear it. That's just what I want to say.
Oh, no. We're not stopping. We've got to know. Well, we're not stopping. I mean, for the year, we've got programs, but let me
let me tell you this. You see, there is a group of women in Port Harcourt. They are doctors, Medical Women Association, the River State chapter. Every year they go into the remote areas. I know they were in Bayelsa, the creeks, those very, very remote areas. And they go and do free cervical cancer tests. Most of the time, I tell you, the result always comes out like, it's always like 1 in 20 or 1 in 10. They always, that they will now follow the case up properly to the end. You see, the truth of the matter is that we need a lot of orientation. We need a lot of awareness program to be able to put this thing into it. And this is a good thing that we're doing, I think. And then like we said, okay, not so many men are on this forum, yeah, but I can tell you something. A lot of us those of them that are here, they will also benefit something, and it's not. Don't despair. Don't say
No, I'm not. No, I'm not despaired. I'm not. No. We're not going anywhere. We're here to stay.
Yeah.
I'm just trying to say that, for instance, if anybody has a community they think will benefit, it's easy to talk about it. But in the same conversation, awareness is a very expensive program to run, and it is very important that once we want to do it, let's do it properly. I will give you a typical example. Keeping my fingers crossed post-COVID. If COVID allows me before the end of the year to be able to go back to Nigeria, I am intending to host something in Lagos in December. That is if COVID allows. But even in that, we've still got to raise the funds to be able to do that. And COVID is not allowing the movement to do that. But we will still keep hanging in there, send out the messages, ask people. The only challenge is, like you said, small communities are the way forward. But unless you're in the system, the people in the system think it's another person's illness. Most of us on this platform are today, I'm looking at the screen now, live in England or America. There are only about four or five people here that live in Nigeria. Which
the truth of the matter is that
all I want is for people to also go out and talk about it. If we talk about it and say, I know somewhere, okay, if you've not heard, go onto this platform and hear about what's going on with cancer, then it does help.
The big message here is that cancer is not a death sentence.
Oh, no, it's not.
You said what?
I said, oh, no, it's not.
It's not a death sentence because there is a general belief. Once people hear cancer, it's like, in fact, there's always that. But we just have to keep on telling. It's not a death sentence. It's curable. It's treatable, and people are surviving it. A lot of people are surviving it, and when they hear stories from survivors, they'll be encouraged. And then, because why do people say it's not my portion? Because they don't. Everybody wants to live in denial. I don't want it. You know what? Nobody wants it. But the reality is there. If you have it, what do you do? So
that's why we're here sharing our story.
Yeah, that's why we are here sharing our story.
Exactly, so that everybody else can also help us to share our story and say there are asking people that are there.
Yeah.
Thank you. Any other question? Any question in the house?
Well, please, could I ask a question?
Yes. Who is that? Identify.
Annie from Lagos.
So, Annie, how are you?
I'm well, thank you. How are you?
I'm good. Lost and found. All right, then go on.
Okay. The question I would like to ask, from Femi's experience and your knowledge of Nigeria, each one of us here, would you say that one of the reasons why people also keep away from information about cancer is because of the cost? Everything that is being said about cancer portrays high cost and portrays families mortgaging their lives to take care of just one person. And unfortunately, sometimes eventually the person dies. I think there are more cases of those type of things that have happened. However, I also know that with the correct information, there are some precautions that could be taken from the wealth of information that we have gathered from here today and the previous times. So is it also the fact of when these things are being related to, for people to realize that the cost is not something that is going to cripple their lives and cripple the family?
I think Femi will agree with me. Both of us will tell you the cost. There's no way. That cost part. I don't think either of us are in a position to give any promises. That's a fact.
The truth of the matter is that it's not pocket friendly. Number one.
It's not what?
Pocket friendly.
Yeah,
Okay.
It's not pocket friendly. It's not.
It's not pocket friendly. That's number one. But the thing is that early detection is always the key. You don't want a situation where you will start spending, and then you eventually the person. But if it is discovered early enough, you won't spend as much as when it is discovered late. You understand, right? And the thing, and in fact, that's not even a guarantee whether it's early or something. But it's always better to take all the precautions to detect it as early as possible. There's nothing more. You can't say. How do I say? Whatever the case may be, life is more valuable than money. What I don't know what else to say to that.
Okay. No,
Annie, what we're going to do, let me be very honest with you. We are fundraising, but even our fundraising will focus fundamentally on awareness. As we go along, yes, we do have people. I'm talking from the platform perspective. There are various people that have been and are on the platform who have actually raised conversations about currently in chemo and can't even afford it. Now, there's very limited things that anybody can do, but from my perspective, I am able to see if I can find somebody who is willing to fund that person. And sometimes they may be very willing to fund only a shot, which is a challenge, because even a shot is almost 300,000 naira. And we have to be honest about that. Nobody can say it any differently. The hope is that maybe as we continue to feel encouraged and we continue to share this, gradually people will understand that this is still a platform where you can be honest with yourself. You can actually talk about this, ask the questions that may help in the preventatives, in the early detections, because early detections in cancer, anybody will tell you, is standardly to do with the fundamental hope that you have. Your hope is based around early detection. I don't see how anybody can say differently. Mm-hmm.
Okay. No,
Wale has something to say. Go on, Annie. Do you still have something to say?
No, thank you. Because what the angle that I was also looking at is the fact of in raising the awareness to people, to let them know that they should not be afraid of the cost of cancer, but there are preventive measures that can be taken, like early detection. Diet is something everybody has talked about. But if there are diet, early detection, and if there's anything else that does not actually cost an arm and a leg for them to be able to say, oh, these are the little things that you can actually do. It does not have to mean that it has to be, someone has to give you a bill of 5 million before you start fainting and think that it is a death sentence. That's what I just wanted to say.
Yeah, thank you. But actually, one of the things I'm trying to do, and hopefully with support, a few people are now trying to support in a bit of fundraising, will be to start putting a bit of money aside for early detection, specifically those tests to do with PSAs for men, and for women it will be cervical test. I think that one is also reasonably, the initial test is reasonably okay. Wale has a question to ask. Okay, Wale, or a comment, I don't know. Your mic is on. Wale, your mic is off. Your mic is off. You need to put, okay.
Yeah, good evening all. Yeah, it's I just want to touch on two issues that you've talked about already, which is the awareness, raising the awareness of this thing. And I'm looking at it from the inhibitors of why Nigerian men actually are reluctant to do this. And I see two things. The first one is cultural, which is related to the second one, which is the relationship they actually have with their specialists, doctors, and what have you. So the cultural aspect is, if you think about it, once we become 40 and 50, we are usually big men in Nigeria. So what that implies is that for us now to have doctors or specialists, they are most likely going to be your friend, your wife's friend, your friend's wife, and some people we know. And that I personally found with my brother that it's a big, big thing. Because how will I go and drop my pants for this small girl who is who is this person's girlfriend or this person's wife or this person's sister. And that brings me back to the awareness issue. And then these doctors now do not tell it as it is because of that same relationship I found. And that's from personal experience with my mom. My mom didn't have this cervical, she had a renal cancer. And my brother took her to his best friend. The guy looked at her and said, there's nothing they can do, that we should just give her palliative. That was the first time I would hear the word palliative. So what we did was, touching on another point Ebon raised the last time, is seeking a second opinion. I said, actually I told Angie, and Angie said, oh, no, we have to talk to somebody else. Let's talk to a doctor friend that is here. Lo and behold, we found out that she was actually treatable. We brought her here, and after this specialist from LUT, who is my brother's best friend, or not best friend, who is my brother's good friend, and I actually fell out with my brother because of this, when I was saying we need to seek a second opinion. I said, no, what are you talking about? This is my friend. It's as if he was doing us a favor. Anyway, to cut a long story short, Angela said, that's my wife. We need to bring your mom here. She came here, and she lived happily ever after for 15 years. So going back to my point, I've been having discussions with my brother again about him having himself checked. He was complaining about how he was weaned a few months ago. And I said, Big Sheikh, when was the last time did you actually do a check for this? I said, I can't remember. His doctor is his friend's cousin's wife or something like that. So it has to come, one, from the awareness you've raised, but where does this awareness fit in? It plays from both sides. The doctors themselves, in Nigeria, doctors are demigods. Whatever they say seems to like the gospel. So if we can get doctors on board,
that would be a good one. That's right.
Okay, go ahead.
So if we can get doctors on board to help spread this message, I think that would be helpful. I'm not very religious, so the churches Angufemi raised, the churches give you anointing so that it won't catch you. So it might affect their teeth. But yeah, that's just what I wanted to add to it.
Thank you. Thank you, Wole. One of the things I would like everybody to know is that as we go through these conversations, we put a lot of points together, and it's also helping to build the concept and the ideas going forward and the strategies that would most probably help us to continue to create an awareness. Fundamentally, as I've said, Common Cancer Foundation is focusing on awareness, and early detection is the first one. We're not into treatment plans and all that, but let's see how things go. Femi,
Yep.
I'd like to say a very big thank you for your time, for engaging, for all the talk, for being part of this initiative. Let me put it the right word, this initiative, because with a survivor talking, and hopefully with more people being happy to talk about their experiences, we will hopefully be able to touch more lives and touch more people all around, and gradually be able to raise this awareness that is a fundamental target, especially in Nigeria. So everybody knows Common Cancer Foundation is actually funded for cancer support in Nigeria. And then after that, we'll look at everywhere else. But for now, it's Nigeria. I want to say very big thank you. Thank you for coming on board. Thank you for for speaking to us today. Thank you for giving us your time. Is there anybody else that has anything else they want to say before we end? Our 1 hour is slightly over, but we started 5-10 minutes late. Anybody? Okay, you can follow us on Commonwealth Cancer Foundation on our Instagram page. Give us comments, give us feedback. We also have the Commonwealth Cancer Foundation page on Facebook, and we're working, almost getting close to bringing out something for our websites in the very, very, very soon future, hopefully before the end of August. And then we can start to look at our fundraising activities. However, our account numbers can be retrieved from any of these pages as well. I want to thank everyone for joining. I want to appreciate your time and thank you for your time. And most importantly, please share the talk, share this experience, share the discussions with your friends. And I think in the next 1 week, by next week, Commonwealth Cancer Foundation videos will start to go up on, I'm sure it's going up on YouTube. I'm waiting to confirm if it's also going on IGTV. And once it does, we will put it on the page, on our social media handles for people to be able to share with their friends and hopefully create an awareness. I want to say a very big thank you to you all for coming, and I hope to see you soon. In 2 weeks, our next one is the talk from a carer's perspective. So all your friends who are carers, who are struggling to be a carer, who just don't know what to do, you can come online and watch a carer's perspective. This time is a carer going to be talking and how they were crying and all the things they went through. So thank you all and have a good evening. Femi.
Thank you.